Hello, welcome everyone to the PrecisCa Lung Cancer Tumor Board. I want to welcome all our panelists today. I am Ramaswamy Govindan, a medical oncologist at Washington University in St. Louis. I'm joined today by our experts. We'll start out with the introductions. Dr. Ginsberg.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging and Vice Chair for Education at Memorial Sloan Kettering Cancer Center and Professor of Radiology at Weill Cornell Medical College.
I'm Larry Keston. I'm a radiation oncologist in the Detroit, Michigan area for Michigan Healthcare Professionals and Genesis Care USA Medical Director in Michigan.
I'm Tom Stinchcomb. I'm a medical oncologist who specializes in thoracic oncology at Duke University in Durham, North Carolina.
Hello, I'm Dr. Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of General Thoracic Surgery at Emory University Hospital in Atlanta, Georgia.
62-year-old patient with a history of early stage non-small cell lung cancer who had a recurrence in the hilum. And this patient presented with fatigue, cough, hemoptysis, and shortness of breath, had a good performance status with no significant medical history except for hypertension, 40-pack history of tobacco smoking with no history of drug abuse, a history of alcohol abuse in the past, but then quit 10 years ago with no family history of cancer. Back in September of 2016, this patient had right lower lobe lobectomy for a T1bN0M0 squamous cell carcinoma measuring 2.4 centimeters without any lymphovascular invasion, and margins were negative. We can review the CT scans. Dr. Ginsberg, please.
We see that there's been a recurrent soft tissue mass surrounding the bronchus intermedius. And this mass also extends to involve the right pulmonary artery, not included on these views, as well as other branches of the right pulmonary artery. It is FDG avid, as seen on the PET-CT, and no other metastases were seen on the PET-CT. So essentially, there's this recurrent mass encasing the bronchus intermedius and involving the adjacent pulmonary artery and branches.
Thank you, Dr. Ginsberg. So the bronchoscopy of the hilum in November of 2018 revealed squamous cell carcinoma. The PD-L1 expression was 70%, EGFR wild type, no ALK rearrangement, and deemed not to be a surgical candidate, and received radiation therapy, hypofractionated radiation therapy to the right hilum, 60 gray in 12 fractions, and was then initiated within a month with paclitaxel, carboplatin, pembrolizumab. And now the question really to the panel is that how would we manage this patient? And we'll start off with a comment from Dr. Force about the surgical resection of locally recurrent disease. Do you want to comment about the surgical options first?
Certainly. So, it's not necessarily that uncommon that we face this situation. And, given, a healthy patient is certainly is an option. It often involves a completion pneumonectomy, as it would in this case when the bronchus intermedius is involved. The upper, you're not going to get a margin on the upper lobe. So the upper and middle are going to have to come out, especially with involvement of the PA. So assuming the patient had good enough pulmonary function to tolerate the rest of that right lung coming out, a completion pneumonectomy would be an option for that person.
Thank you. Thank you, Dr. Force. Dr. Keston, so there are several questions here. What is the optimal radiation therapy? And can you please educate us about the hypofractionated radiation? Is this what you have done?
Sure. And this is an interesting case and a somewhat common situation. I would say probably the most standard regimen in my experience in this particular situation might be concurrent chemotherapy with standard fractionation radiation treatment, followed possibly by further systemic therapy, in which case, from a radiation oncology standpoint, I would be giving more like 60 gray and 30 fractions along with concurrent chemotherapy. This is also, the regimen that was chosen is also a reasonable consideration. If one is wanting to push for slightly higher local radiation doses for long-term local control, you cannot really give classic SBRT stereotactic body radiation therapy, which is even higher doses per fraction, such as 10 gray times 5 or 12 gray times 5 in this particular location due to the possibility of toxicity. But one could use a regimen such as 6 gray times 10, or I don't personally use that regimen myself, but you could use 5 gray times 12. And then, regimens such as that are what we call hypofractionated, meaning, the entire treatment course is delivered in a fewer number of total treat fractions. Typically in that situation, it would not be recommended to give chemotherapy simultaneously with the radiation treatment. So that's why it was, I think, chosen to give the systemic therapy after that particular treatment regimen.
So do you feel that the hypofractionated regimens are better than the conventional radiation treatment? Imagine a situation where we are not giving chemotherapy or immunotherapy. What is the advantage apart from limited visits to the radiation therapy center?
Well, studies more so in the early stage setting, such as a stage 1 medically inoperable non-small cell lung cancer. In that setting, hypofractionated regimens, typically stereotactic body radiation therapy, meaning 5 fractions or less, high dose per fraction. Those regimens have definitely a higher local control rate than standard fractionation. So if one is treating a stage 1 medically inoperable non-small cell lung cancer, I would always prefer that regimen if I can use it. Because you're giving a higher dose per fraction, that can cause more side effects, more toxicity in certain situations, especially in more central locations, such as this anatomic location in this particular patient. So, one would not typically choose SBRT. One could choose the type of regimen that was selected if in an attempt to obtain a slightly higher local control. Again, in my practice, for a case such as this, I would typically do something a little more what I would consider standard, concurrent chemotherapy with more standard fractionation radiation treatment.
Thank you, Dr. Keston. Dr. Stinchcomb, if this patient had come and seen me, I would have given concurrent chemoradiation, like the way Dr. Keston was mentioning, followed by durvalumab. What are your thoughts?
I think I share your and Dr. Keston's opinion. I think for these patients who have a local recurrence, especially this patient had, a 2-year disease-free survival, I've treated them more with concurrent chemoradiation therapy, followed by the consolidation durvalumab. I think you are sort of at a philosophical crossroads. You consider this patient a stage 3 patient or a stage 4 patient, and I've generally decided to treat him as stage 3 patients and follow that paradigm.
We have to concede, though, that, correct me if I'm wrong, the Pacific trial did not include patients who recurred locally. It only included patients who are de novo, newly diagnosed with locally advanced disease. So it is, we don't have level 1 evidence to suggest that, but historically, we have been treating these locally recurrent non-small cell lung cancer patients without surgical options with chemoradiation in the past, before the days of durvalumab. And, in our experience, I'm sure all of you would share this too, that we have had patients who have been cured with this kind of regimen. And so we would pursue that. You agree with that?
I agree with that, and I think that's one of the reasons why that has been the preferred therapy, thinking that that's a more aggressive therapy and provides a better chance at long-term survival than the stage 4 paradigms.
Dr. Keston, I'm sure you get asked this question all the time. Can I get proton therapy? Any comments on this?
Proton therapy is an option for a situation such as this. Typically, with photon treatment, this is really not that difficult. Usually you might do the proton therapy in a reirradiation situation here. And even if you are delivering this treatment with protons, it's not going to allow you to do SBRT in this particular instance. So personally, in my opinion, I would say there is not an advantage to proton therapy in this particular case.
Great. Very good. So to summarize this discussion, this is a problem of having locally recurrent disease following surgical resection with no distant metastasis, not surgically amenable. So we would treat this patient like a locally advanced non-small cell lung cancer, unresectable, with concurrent chemoradiation using conventional photon radiation treatment, conventional fractions with chemotherapy, concurrent radiation, concurrent with radiation, and then followed by consolidation durvalumab. And that's the key message that this tumor board would like to convey to our audience. I think all of us feel that these patients have potentially curable disease, and we would treat them with proven therapy for locally advanced non-small cell lung cancer. Thank you for that wonderful discussion.